doctor. Female infertility is a challenge that might need a comprehensive complementary therapy plan. This is Nora, your AI assistant from Eva Pharma, and today I would like to share with you the role of L-arginine in female fertility. L-arginine is the precursor to nitric oxide, which promotes uterine blood flow and correspondingly improves follicular growth, oocyte quality, and fertilization rate. Literature shows that L-arginine supplementation in IVF poor responder patients increased the number of oocytes collected and transferred embryos. Also, a prospective observational study on women with thin endometrium, published in the American Society of Reproductive Medicine, claims that the use of L-arginine improves the endometrial thickness and improves the uterine radial artery resistance index. Carnivita Advance for Women is an integrated fertility formula that contains 500 mg of L-arginine along with 12 more powerful elements to support female fertility and reproductive health. Carnivita Advance for Women. Enhance her chance. Hello doctor, I am Nora, your AI assistant from Eva Pharma. Today we will be discussing women's menstrual irregularities and hormonal imbalance. 90% of women with menstrual irregularities and 80% of women with hyperandrogenic symptoms like acne, excessive facial hair, or hair fall, have polycystic ovarian syndrome. Polycystic ovarian syndrome, or PCOS, is the most common hormonal disorder affecting women of reproductive age. It affects almost 1 in 5 women. One of the hallmarks of PCOS is increased oxidative stress, which is caused by an imbalance between harmful free radicals and the body's natural antioxidant defense system. Carnivita Advance for Women is a food supplement, an integrated formula of 13 powerful antioxidants that help PCOS patients reduce oxidative stress, potentially restore ovulation, normal menstruation, hormonal balance, and also relieve hyperandrogenic symptoms, enhance insulin sensitivity, and most importantly limit potential PCOS consequences and long-term complications. Carnivita Advance for Women recommended dose is 1 sachet per day for 3 months. Eva Pharma, securing your health. Hello doctor. Female infertility is a challenge that might need a comprehensive complementary therapy plan. This is Nora, your AI assistant from Eva Pharma, and today I would like to share with you the role of L-arginine in female fertility. L-arginine is the precursor to nitric oxide, which promotes uterine blood flow and correspondingly improves follicular growth, oocyte quality, and fertilization rate. Literature shows that L-arginine supplementation in IVF poor responder patients increased the number of oocytes collected and transferred embryos. Also, a prospective observational study on women with thin endometrium, published in the American Society of Reproductive Medicine, claims that the use of L-arginine improves the endometrial thickness and improves the uterine radial artery resistance index. Carnivita Advance for Women is an integrated fertility formula that contains 500 mg of L-arginine along with 12 more powerful elements to support female fertility and reproductive health. Carnivita Advance for Women. Enhance her chance. Hello doctor, I am Nora, your AI assistant from Eva Pharma. Today we will be discussing women's menstrual irregularities and hormonal imbalance. 90% of women with menstrual irregularities and 80% of women with hyperandrogenic symptoms like acne, excessive facial hair, or hair fall have polycystic ovarian syndrome. Polycystic ovarian syndrome, or PCOS, is the most common hormonal disorder affecting women of reproductive age. It affects almost 1 in 5 women. One of the hallmarks of PCOS is increased oxidative stress, which is caused by an imbalance between harmful free radicals and the body's natural antioxidant defense system. Carnivita Advance for Women is a food supplement, an integrated formula of 13 powerful antioxidants that help PCOS patients reduce oxidative stress, potentially restore ovulation, normal menstruation, hormonal balance, and also relieve hyperandrogenic symptoms, enhance insulin sensitivity, and most importantly limit potential PCOS consequences and long-term complications. Carnivita Advance for Women recommended dose is 1 sachet per day for 3 months. Eva Pharma, securing your health.
طيب الحين انا ايش احط نفسي في
وبعدين على طول بعدها هذا. طيب شكرا.
سمير الصوت كويس الآن؟ أنت مقفل الميكروفون على فكرة.
ممتاز دكتور بدوش، سمع حضرتك كويس.
صوتك واضح يا بروف، بس انا اقفل عشان الصوت، عشان لا يصير في صدى ولا شيء. لما انت تبدا تتكلم انا اقفل على طول الصوت والكاميرا. لكن صوتك واضح وكل شيء ممتاز.
I'm sharing the screen now.
Yes, it's clear.
Okay, good.
We'll wait until 2 o'clock, then we'll start our webinar.
ماشي.
Just I want to inform everybody that now, because the Zoom we reach 1,000, so we are transferred to YouTube, and it's already now in the YouTube. So please join us. It will be directly. You will be transferred to the YouTube. So welcome to the YouTube, please.
السلام عليكم يا بروف ممدوح.
هلا وسهلا بروف أيمن، هلا وسهلا، حياك. كيف الحال؟
عاش من شافك يا بروف.
إن شاء الله نشوفك قريب بإذن الله.
على خير إن شاء الله.
حياك الله دكتور أيمن، الله يحييك.
أهلا دكتور سمير، يا أهلا وسهلا، كيف حالك؟
نورتنا، الله يسلمك بوجودك.
الله يسنورك، الله يسلمك ويسعدك. الله يكرمك، إن شاء الله نشوفك إن شاء الله يا دكتور سمير قريب برضو على خير.
إن شاء الله وأنت طيب. والحقيقة وجودكم كان لي فعل كبير عندنا في الويبينار، يعني اللي بيستمعوا ليكم مو بس في المملكة العربية السعودية، بتجينا رسائل الآن من بحرين وحتى من فرنسا. فدحين الزملاء لين وصلنا 1000 هذا، فدحين على اليوتيوب وصل العدد 500. فنتشرف بوجود جميع الزملاء وبجميع البارتيسيبنت.
تسلم يا دكتور سمير، تسلم. هلا دكتور حمد.
يمكن دكتور حمد حيدخل شويه متاخر، ما ادري، ماني شايفه، بس هو قال حيدخل شويه متاخر عشان الظروف.
الله ييسر ان شاء الله.
سمير، كيف أبعد الشاشات هذه الصغيرة اللي على الجنب عشان لا تغطي لي السكرين؟
اضغط برزنتيشن يا بروف ممدوح. شوف تحت هنا انقر تحت، انقر لإضافة الملاحظات.
انقر لك؟
إيه.
فين النقرة هذه؟
حتلاقي في سبونسرد باي ايفا فارما تحت، شايفها؟
ايوه.
فوقها في كده 4 مربعات صغيرة، في واحدة منها صفرة، شفتها؟
هايد.
لا
أيوة.
مو هايد، اللي مكتوب 94. شفت 94 اللي فوق سبونسر؟ اللي جنب 94 على طول اضغطها
بس خلاص شلت البقية، وباقي سمير وباقي أنا اللي شايفهم يعني، فكفاية علي سمير.
تسلم. shall we start? السلام عليكم ورحمة الله. السلام عليكم ورحمة الله وبركاته. It's our pleasure that to start women's health this day, Friday, with a prominent speaker. It's about women's. Can you close please your mute? So we'll start our women's health and IVF, this with the presence of highly actually our speaker. We have Professor Mamdouh Iskandar, we have Dr. Hamad Al-Sifayan, Dr. Ayman Arif. The beauty that they are from different part of Saudi Arabia, and they are the top people who are working in IVF. It's our pleasure that they will join us today, and it's a privilege for me to be monitoring for this webinar. I would like to thank Top House Conference for their activity and registering our colleague, on the same time for their actually helping us for webinar. On the same time, I would like to thank IFA company and Dr. Rami for their high effort for them sponsoring this webinar. Since we are reaching 1,000 now on the webinar before we start, and the people, they are going to be transferred to YouTube now, more than 500 on the YouTube, and this shows how it's actually highly, this one webinar is important, and IVF with the presence of prominent speaker. I would like to represent the first speaker. He's my colleague, Prof. Mamdouh Iskandar. He's He's an obstetrician and gynecology from Saudi Arabia. He was obtaining his MBBS from King Saud University in 1989. He completed his Canadian board in obstetric and gynecology from Canada in 1997. He went to obtain subspecialty in reproductive endocrinology and infertility from University of Western Ontario, Canada in 1999. He is present professor of obstetric and gynecology, and he's the chairman of the department at King Khalid University, Saudi Arabia. He has been an author for more than 40 research papers in both national and international journals. And on the same time, I would like to welcome the people who are from outside Saudi Arabia, from Bahrain, Qatar, Kuwait, because we noticed that some people have been registered from outside Saudi Arabia and also from France. So I'd like to thank them for being present with us, and welcome Prof. Mamdouh, who will talk about keys for success in IVF programs. This webinar is actually with for CME. So welcome to all our colleagues. Welcome, Prof. Mamdouh.
طيب السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا, and good afternoon to everybody. And since we have somebody from France, I'm sorry I don't speak that good French, so I would just say bonsoir. Maybe this is gonna work. And I wish you're gonna enjoy my 25 minutes talk on the keys for success in IVF programs. And I think this is a quite important introduction, I would say, to today's presentations, talking about the how to improve and how to get the best results out of the IVF programs. And if you look actually on what's happening nowadays in the science of assisted reproduction technology, you will find that this kind of science is moving too fast, like any other science, so we got to catch up with it, or otherwise we will be lagging behind in the field of assisted reproductive technology. We know that about 10 to 15% of the population, they have an infertility problem, and out of this 10 to 15%, they will end up conceiving using or undergoing assisted reproductive technology. The way to improve our programs and the way to improve our pregnancy rate is lots of factors gets into this by using different stimulation protocols, by using the agonist, by using the antagonist. And if you notice that the majority of our patients, they will reach to the transfer stage, but the real question is who's going to achieve a clinical pregnancy rate? And this is what we will be talking about in the coming 20 minutes or so. The average pregnancy rate in most of the IVF center programs, it ranges from 45 to 50%. I know that few centers, they claim to have a pregnancy rate of much higher than 50%, let us say 80 or 85%. I think this is a kind of a bit exaggerated. So let us look into the success rate of 45 to 50% and a maximum of 60% if you can achieve 60% in your IVF center. And they always say it takes two to tango. And as a matter of fact, in IVF and the assisted reproductive technology unit, I wouldn't say it takes two to tango, but I would say it takes three to tango. And if it doesn't happen, those three factors, they don't tango together.
I interrupt you, Prof. Mamdouh. I think your presentation, you put only the first slide. You didn't change it. So you need to change whenever you talk.
So I am changing it actually. How?
But we are seeing the first slide.
Oh, okay.
Can you stop share and reshare? Stop share and reshare again. Share again.
I'm sorry. Are you seeing now the slides moving?
No. Stop share and reshare.
Okay.
Share from top.
Stop the video.
Top share. We'll find out.
Well, let me stop the video and see.
I will stop from my side. You can share again. You can share again.
اللي جايين هذا فيصل.
Yes.
How
Yes,
about
perfect.
now?
Yeah, perfect.
Okay. Now it's moving, I guess.
Yes.
Yes.
Yes, it's moving.
Okay, excellent. So I think we got up to this slide. So if these three untangled together, that means there is something wrong. And if you look at it from the point of view that how could we improve our success rate in IVF programs, we get to depend on two major influences that will shape the management of the infertility in the recent years. We get to look into the effect of the evidence-based medicine, as well as we get to look into the availability of in vitro fertilization and its new related techniques that is being put into the field. So these three factors that we will be looking at, number one is the patients, number two, the ART physicians, and number three is the ART lab and your embryologists. So the patients, we get to look into the of infertility, which will be based on the evidence-based medicine, the age of the patient, the trial number that the patient had before. And you get to look into the ART physicians, the physician's experience, the stimulation protocols that they are using, the stimulation drugs, and the OPU and the ERT and the embryo transfer stage. So ART lab and embryologist, you have to have a senior embryologist who's going to run the lab for you. And to be fair to your embryologists, we get to remember one thing, that our embryologists, they have the custody of the gametes and the embryos from the moment that the egg is being aspirated to the sperms, and the sperms are being ejaculated till the expelled of the embryos from the transfer catheter. So all points of contacts and handling have potential impacts on the outcome. But why I said we get to be fair to the embryologist, because the embryologist cannot produce good quality embryos from poor quality oocytes. So what happens in such cases, if you give your embryologist a good embryo or a good oocyte or a bad oocyte, if you give them good oocytes, your embryologist is going to give you good embryology, good embryo. But if you give them bad oocyte, the embryologist is not going to give you as good as the embryo that we have seen. So we get to remember this point which is considered to be a very important point. Giving your embryologist good oocytes, he's going to give you hopefully good embryos. So the optimal technique and the expertise in this field plays a major role in determining the embryo quality and the consequences that is going to happen after that, which is IVF outcome. The quality control has a very important role to play, a major role. So when the embryologist, even he's producing good embryos for you, but you are mishandling or misplaced or dislodged the embryos back from the cervix, you are not going to achieve a good pregnancy rate in such a stage. So to increase your pregnancy rate and to increase your success of your embryo, you get to have positive and negative factors. there are lots of positive factors that play roles in this stage. Cervical lavage that we do, which is we're using it by the mucus aspiration catheter, the type of the catheter that we are using, and loading the embryos either by limited volume or by air, and the presence of a trial transfer, which has 3 positive signs. So a trial of a transfer before you do your embryo transfer is quite important, because it will increase definitely your pregnancy rate. Cervical dilatation, if necessary, in cases if the presence of a trial of a transfer is quite difficult. And nowadays, I guess everybody is doing the embryo transfer under ultrasound guidance. The negative impact that you have, and it will reduces your pregnancy rate immediately if you get your catheter, there is a blood on your catheter. So immediately you would know that your pregnancy rate has been reduced. The mucus on the catheter tip, or if you have retained embryos, and the bacterial contamination. This is why most of the IVF centers, they would give IV antibiotic on the day of embryo transfer, or preferably on the day of the ovum pickup. So these are quite important factors. Pregnancy rate is significantly increased when there is a trial transfer, when you are using a soft embryo catheter, when you are using the ultrasound guided embryo transfer, and where you place the embryos. And this is quite important. So you will not end up in a dislodge of the embryos down to the cervix, or you will not end up into an ectopic pregnancy, which is one of the complications of the embryo transfer. So now let us take one by one and each factor by itself, and let us look into the patient's factors. And there are lots of patient's factors on the evidence-based medicine says that if you follow these factors, you might increase your pregnancy rate or you might reduce your pregnancy rate. The different causes of infertility, the female age, the number of embryos that is being created in the lab, the previous pregnancy, AMH, number of previous IVF cycle, and so on and so forth. So let us look into what does the evidence say regarding the female age, the number of embryo transfer, the ovarian reservoir, duration of fertility, etc. So the first slide here regarding the age, right? We all know that increased female age will lead to decrease, and this is proven by the evidence-based medicine. Is in the age. This is why even in some centers, they will take the cutoff point of their, including the patients into the program or not, as for instance, 40 years of age, because they want to keep certain pregnancy rate in their centers. So patient's age is quite important, and this is being proved that increase the patient age will increase. So especially for those who are IVF programs, the best thing is to start with the young age group. Or even if you want to go for 40 and beyond, you got to in specific of their pregnancy rate if you are willing to do 40 years and above. So female age, this is the first important factor in patient's factor that will lead to increase or decrease your pregnancy rate. And then if you look at the duration of the infertility, a patient who has a duration of infertility of 20 years, she definitely will have a lower pregnancy rate than a patient who has a duration of infertility of 5 years. So again, for centers who are beginning and who are starting their IVF programs, the best thing to get to choose, and I'm not saying to decline or to ignore the patients who are 37 years of age or above, or 40 years of age or above, or if they have a long history of duration of infertility, but you get to counsel them in a proper way that their pregnancy rate is not going to be as high as a patient who has a duration of infertility of 5 years. And this is again being proved by the evidence-based medicine. The prognostic value of women who had previous IVF cycles, it is very important. Patients who get pregnant before, whether ended up in a live birth pregnancy or ended up in a miscarriage, they have a higher rate of pregnancy by doing their IVF. So these are quite 3 important factors so far we have discussed: the age of the patient, the duration of the infertility, and number 3 is whether she had a previous pregnancy from IVF or from spontaneous pregnancies. Now, we looked into the number of eggs that we retrieved. We all agree that we have something called friendly cycles, that you don't want really to retrieve more than 10 to 12 oocytes. But the number of the embryo not being transferred, but the number of embryos being created in the lab and being formed in the lab is quite important. The number of embryos being transferred is a different story. You might transfer, and now in most of the European countries, they do the ESET, the elective single embryo transfer, or the SET single embryo transfer. And in some programs now, you are not allowed to transfer more than 2 embryos in certain countries, and you're not allowed even to do cryopreservation. But if you develop in your lab good number of oocytes, as well as good number of embryos, that will take you to go into the blastocyst stage, which is day 5 embryo transfer, you will be having a higher pregnancy rate, regardless whether you are doing a 3 embryo transfer on the day of the ET, or you're doing 2 embryo transfer, or you're using, according to the rules and the regulation of some countries, you're doing ESET or SET single embryo transfer. So the number of and this study is coming from a meta-analysis of 4 studies, increasing the egg numbers, resulting in increasing the pregnancy rate. And now the lifestyle plays a major important role regarding taking big amount of caffeine, whether the patient is a smoker or not, and whether she drinks alcohol. So all these factors, if you combine them together and if you keep them in mind before you start your IVF programs and before you choose your patient, I think you're going to end up having not 45 or 50% chance of getting that patient pregnant, but even higher than this, and you maybe achieve like 60% pregnancy rate in IVFs in your IVF center. The effect of cigarette smoking, again, is being proved by a meta-analysis study, provide evidence for significant negative effect on patients who they smoke any kind of cigarettes, whether it's cigarettes, whether it's a different kind of tobacco, shisha, or whatever they are smoking. So my advice is, if the patient is a smoker, we should ask her to quit smoking for at least 3 months prior to her IVF cycle, and this would improve your pregnancy rate. Another quite important factor, that most of the centers, they do not have a psychologist in their IVF center. I think the presence of a psychologist in the center to counsel the patient and to reduce the amount of stress that the patient is going to be exposed to during the treatment cycle, or even if she gets pregnant, or even if she gets a negative pregnant, is quite important. So one of the recommendation, and the strong recommendation, is, of course, we as IVF physicians, we do counsel the patient regarding the a bit of the psychological aspect, but I think it's quite important to have a psychologist after we decide on the treatment. For instance, this patient is going to go for IVF, or this patient is going for intracytoplasmic sperm injection, we got to transfer the patient to our colleague psychologist who is just sitting next door, who's going to inform her about all the psychological aspect of going under the treatment of an IVF cycle. And this by itself is going to reduce the amount of stress that the patient is going to be exposed to. And by reducing the amount of stress and all the hormones that related to the stress, this will improve our pregnancy rate. So now, these are proven factors that we have talked about. And if we do it, as I said, it's going to improve your pregnancy rate. Now, there are some centers that they should or they shouldn't do, and because from the point of aspect, whether it should increase your pregnancy rate or not. So the first thing is they say, well, we cannot give general anesthesia, or we should do paracervical block, or we should do just IVF sedation. As a matter of fact, many studies have been published regarding using the gel xylocaine, regarding using general anesthesia, regarding using paracervical block, and so on and so forth. And it has proven that there is no improvement in the results one above the other. So if you're using general anesthesia, this will not damage your oocytes, and it will not affect your oocytes, because I know in certain IVF programs or centers, they are using routinely the IVF, they're using routinely the general anesthesia. So no worries, you should carry on if this suits your center and if this suits your patients, and she cannot tolerate the paracervical block or the IVF sedation, you can carry on using the general anesthesia. This is a very interesting study I came across. It's a comparison of the success rates of embryo transfer on the weekdays and the weekends. We try most of the time to avoid doing embryo transfer or doing even ovum pickup on the weekends. But this kind of interesting study I came across, it showed that the embryo transfer performed during the weekends were more successful than the embryo transfer performed during the weekdays. I'm not really sure why they had like an improvement in their pregnancy rate when they were doing it, because maybe like they were not in a rush, they were not having so many cases during the weekends. There was no really good explanation for this. So, but I thought it's kind of interesting study, and I thought I'm just going to present it in my presentation. Lots of our patients, they will ask for bed rest after the embryo transfer. Whether the bed rest is a doctor, please, I want to stay on the bed after the embryo transfer for half an hour or for 1 hour. Or in some physicians, they recommend to stay on bed for an hour or half an hour again. And does this really improve your pregnancy rate? From this systemic review and meta-analysis, it showed that there is no improvement in the pregnancy rate. Another should or we shouldn't do is the effect of flushing with the follicular fluid on the implantation rate. Some, they do injection of the follicular fluid into the uterine cavity in candidates for IVF, and they found there is no increase in the pregnancy rate if you do such a procedure. Another procedure that it was coming into the picture about maybe like 10 years ago, they were talking about the scratching of the endometrium prior to the embryo transfer. Does the scratching or the injury of the endometrium improve your pregnancy rate? Should we or shouldn't we? The answer is we shouldn't, because again, it's not going to improve your pregnancy rate. So the influence of AMH, the anti-malarial hormone, on the IVF success. And in certain ages, I think anti-malarial hormone plays an important role in counseling your patients, but it's not all patients, they should have anti-malarial hormone done for them regardless of the age. So we wouldn't recommend that anti-malarial hormone should be done for all of your patients, but it's quite important at certain age group. AMH will help you counseling the patients regarding the pregnancy rate. The role of paternal obesity on the success of intracytoplasmic sperm injection. Paternal obesity had no effect on the intracytoplasmic sperm injection, and it will not improve or decrease your pregnancy rate, provided that your semen analysis is normal. If the semen analysis is abnormal, then this is a different story that you should recommend to your patients that, or to the paternal cause, that he should reduce the weight, because sometimes just by asking the husband or the partner to reduce the weight, this will improve their pregnancy rate and this will get them pregnant even without using. So in conclusion, I guess I'm reaching up to the end of my presentation. The keys for success in IVF programs: you have to have patient selections. It's quite important and very important. You have to have senior embryologists in your lab, and you have to have the state-of-art technology in your IVF lab as well. And you have to have a senior IVF doctors who have all the controls, especially when it comes to the embryo transfer stage. Paramedical team taking good quality and good control quality of your lab and your operating room play an important role. So all of these factors, all of the above, plays major important role in increasing your success rate in IVF program. And just of a notice here, we are talking about ultrasound guided embryo transfer. Now they are kind of introducing a hysteroscope, I would say, that will introduce your embryos through this catheter into the uterine cavity. Though we are not sure yet about the gas that they are producing inside the uterine cavity, and we're not sure about the amount of light that we are harming the embryos by using intense light and by using the CO2 gas, too much of the CO2 gas inside. But this instrument is like a hysteroscope, and it's still under study whether it should be used during the embryo transfer, or we will say it's good enough that we are doing the embryo transfer not under clinical touch, but we are doing it under ultrasound guidance. So to conclude my presentation, and my take-home message is ART is a teamwork, and every member has a highly regarded role in success rate. I guess this is how I'm going to end my presentation, and thank you very much to everybody.
Thank you very much, Prof. Mamdouh, for your interesting lecture. I would like again to welcome everybody in the YouTube, because now above 2,000 in the YouTube because of the presence of prominent speakers, Prof. Mamdouh, Dr. Ayman Arif, and Dr. Hamad Al-Sifayan. I'd like to welcome Dr. Hamad Al-Sifayan. He's a senior of IVF colleague. He's always responding to us whenever we ask him for help and presentation. As all our colleague, Dr. Hamad Al-Sifayan, he's a consultant OB gynecological reproductive IVF. He's the medical director for Durriya. He is the president of Saudi Fertility Group. He will give us a talk about women's fertility. So welcome, Dr. Hamad Al-Sifayan, and it's our pleasure that you will be with us. So if you don't mind, Dr. Mamdouh, you will close your presentation, and we'll start, yes, and we'll start with Dr. Hamad Al-Sifayan. There are some chat in the questions, so if we could help and you start to answer if something related to you, and we'll leave the rest to the end. Dr. Mamdouh?
Yes.
So, Dr. Hamad Safayani, if you can hear us, so you start. There are some questions in the chat. It will appear to every consultant. So according to the topic, we'll start, he will answer the questions. I answer some of them, which is related to administrative issue. So about CME and so on, which is for CME. All the people who are registered with us appearing in the YouTube or in the Zoom, we are going to be registered, their CME. Yes, Dr. Hamad. Can you hear us, Dr. Hamad? Welcome, Dr. Hamad.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. الله يحييك. هذه فرصة طيبة نسمعك ونشوفك إن شاء الله دكتور حمد.
والله دائما تخجلنا يا أبو فراس بمشاركاتك الرائعة هذه في الكونتينوس ميديكال إديوكيشن للجميع، وهذه لقاءات بس أحرجتني، حطيتني بين اثنين قمة، الدكتور أيمن وبروفيسور ممدوح، والله يسامحك.
تسلم. لكن محبينك والناس اللي يحبوا ممدوح ويحبوا أيمن ويحبوا حمد الصفيان مو بس من داخل المملكة، من خارج المملكة، من البحرين، الأمارات، الكويت، قطر وفرنسا، الآن مسجلين معنا في الويبينار، وهذا لوجودكم، الله يبارك فيكم.
الله يجزاك الخير يا دكتور سمير، ودائما أنت سباق، الله يجزاك الخير ويجعله في ميزان حسناتك. ندخل في الموضوع. أنا بطلع شوية من موضوع الدكتور أيمن وبروفيسور ممدوح على الفيرتيليتي بريزرفيشن برا الاي في اف، برا السبلمنت، فإذا سمحتوا لي. معايا دكتور سمير؟
واضح الصورة وواضح البرزنتيشن. Please proceed.
بسم الله. I'm talking about women preservation, fertility preservation, mainly for women. طبعا في for men for couple. My concentration today is about women fertility preservation. فيها أخذ وعطاء a lot. This is my point of view. نعدي البروفايل. الإيج فريزنج يبدأ ب3 stages. ovulation induction, لأنه usually you get 1 egg every month. If you stimulate, you get many. Then the ovum pickup, then the collection. Not all of them will be good for freezing. So يعني تقريبا 80% will be suitable for freezing. minus 196 below 0. Why egg freezing was not popular before? Because it was slow freezing. The survival was only 20%. Now it is 80% because of fast freezing اللي يسموه egg vitrification. So the technology has changed dramatically. Started 1984, 1986, 1999, then became very popular since 2016 لما كان فيه الفاست freezing. Survival became تقريبا 80%. First Zoe was born in 1984 from fast frozen eggs for a patient who was not married, and this has changed the history since. Slow and fast freezing changed the technology dramatically. slow freezing هذا الفريزنج اللي نعرفه انك you slowly decrease it to 196 below zero لكن ال very fast within a minute. هذا does not allow ice crystals to accumulate on the eggs. This is why the survival of the eggs has become much better. Same idea, but different technology. First baby was born after ovarian tissue freezing from Emirates couple long time ago. And in 2014, before she got married, she frozen her ovarian tissue. It was an idea. It was not a technology. حتى. Now she has their baby Rashid. Egg freezing controversial. شئنا ما بينا. الأوثوريتيز يقول لك والله يخلي أغلب البنات يعرضوا عن الزواج لأن تقول لك ما دام جمدت بويضاتي I will translate that in English. يعني ما يحتاج يتزوج بدري يتزوج متأخر. This is not the idea. Some authority they say إنه egg freezing may make women control their fertility so they can get pregnant whenever they want. لكن حصلنا على fatwa, we obtained the fatwa, you can egg freeze cancer patients. لأنها she cannot get pregnant now, why not other patients? الفتوى صريحة. الهدف فيها حفاظ النسل, keeping your fertility. طيب, if I am non-cancer patient بس عندي systemic lupus erythematosus, I have other diseases, my husband is psychological, أسباب غير السرطانية, we need really to go through it. Rheumatoid arthritis, patient who needs bone marrow transplantation, patient who needs chemo for non-cancer patients, Addison disease, etc. So why not to generalize it to those patients are in need? Wife for husband who's a cancer or psychological patient, she cannot get pregnant, she cannot divorce him, so she needs to survive, to fertilize or freeze her eggs. Women who has special in need children, why not freeze their eggs until she cannot get pregnant now because she are working with her need parents or children. The beauty and characters of egg freezing is it is a long time, more than 10 years. It is a priority of women. She doesn't need to take consent from husband or family. Also, it is very safe. It is good for married and non-married women, mainly because uterus can accommodate fertilized eggs at any age, because the uterus, as we know, is a container. The problem is with the reserve of the ovary. And the chances of pregnancy almost similar to natural. Most important is freeze younger. The golden age for women is before 40s. The younger you freeze, the better, because the quality and the number. every woman has a reserve. It is decreased in quality and in a number with age. We achieved permission from high authority وهيئة كبار العلماء على cancer patient. Why not others, please? And we hope this will be the beginning for fertility preservation, not any other reason. Thank you. من فضل الله يعني غرست سنبلة في حقل الذرية الطيبة لمرضى السرطان بفتوى تجيز ذلك. السنبلة الثانية لمن يخشى نفاذ مخزون المبايض لديهن إما بسبب مرض مزمن أو تقدم العمر. نسأل الله أن يجعلنا وإياكم سببا في تحقيق طلب الذرية إنه سميع الدعاء. بالنسبة للfertility technology, we will go through it just quickly. تجميد البويضات, it passes through different stages. First of all, we have to ovulate. That means you take injections for about 7 to 14 days, plus minus, mainly to get more than one egg. So if I want to freeze, I don't freeze one egg. And then we collect it, then we freeze it. Fast freezing is better, what they call vitrification. Survival is better. And next, it depends. How many I can collect, it depends on you. The younger the age you start, the better. But some women, mashallah, even above 40, they have good reserve. Ovulation induction can cause some side effects like ovarian hyperstimulation, taking injection, but does not يستنزف your reserve, does not. Any other diseases does not cause it, especially if you use it in a programmed way. Of course, the general health, weight, age is very important. The presence or absence of endometriosis is important. We said fast freezing is the best because it is 80% survival comparing to 20% to slow freezing. And most of our units are using fast freezing. Is there any abnormality when I get pregnant from frozen eggs? The answer is no. It has been many studies that there is no chromosomal debility or abnormality. How many can I freeze? Average is about 10 to 12, but you can freeze more or less. It depends on your situation. Because every time we use the eggs, we use 2 together. So it gives you more chances. Chances is when I freeze more and earlier is better. And the decision of pregnancy is mine, overcoming any circumstances like sick parents, sick husband. And thank you. شكرا يا دكتور سمير. دكتور سمير.
Yes, I am with you. Thank you very much for your interesting lecture, Prof. Mamdouh, especially it covers some of the religious and of the new fatwa which is coming from our actually religious people. So thank you for adding this information. There are some questions in the chat we start to answer. So I'd like to ask the speaker the questions which are related to them. Please answer them. We'll leave the questions also at the end. Now I'd like to welcome Dr. Ayman Aref. Dr. Ayman Aref is a senior consultant, associated professor and consultant of reproductive endocrinology and infertility, American and Canadian board. He's a director of assisted reproductive technology and minimal invasive gynecology unit in International International Medical Center and King Abdulaziz University. So welcome, Dr. Ayman. Again, I would like to welcome all our colleague in the YouTube. It reaches to 2,000 only in 2,000 participants on YouTube. So welcome all of them.
Can you guys hear me?
Yes, we can see the titles. Yeah, the use of supplement to improve outcome in female fertility. So welcome, Dr. Ayman. Start, please.
بسم الله الرحمن الرحيم الحمد لله رب العالمين الصلاة والسلام على سيدنا محمد. Thank you, Dr. Samir and Eva Pharma, for giving me the opportunity to be with you guys. And Jum'a Mubarak al Jamia. I'm really impressed by the amount of attendees. I was not expecting this. This is one of the highest numbers I've actually seen in my career. It's a privilege for me to be among senior colleagues, my teachers actually, Prof. Mamdouh, Dr. Samir, and Dr. Hamad. My topic actually complements whatever was being said before by my colleagues. Prof. Mamdouh, about how to optimize outcome. He talked about the technical aspects, things that can happen behind the scenes with physicians, lab, technologies. Dr. Hamad about how to preserve fertility. I will be telling you today about how can we clinically help these patients and improving their outcomes on top of whatever medication we use to stimulate them during the process. So when we are giving supplements, why do we give supplements? The whole goal of patients coming to you is they want to walk home with a baby. And if we can improve their chances of having a baby, which I'll guide you through it as we go through the lecture, why not? And I'll show you the evidence of what you guys can use. So is there actually any added value of supplementing with antioxidants during their fertility treatment? Do we use solo treatment or combination treatments? When we choose a supplement, which elements should we focus on? And what does the evidence say? And what finally we will conclude it with, how long should we give them these supplements? So let's see what's in the literature. There is a very nice Cochrane review that's very recent actually, that looked at comparing antioxidant versus placebo in terms of live birth rate for patients for patients with natural conception. This is not for patients who are undergoing IVF or anything, for natural conception. As then you can see here from the forest plot, it favors antioxidant treatment. So they included multiple studies, and as well we know, when you combine multiple studies, it's much better than when you use a single study. And when they used the forest plot, it all favored the use of antioxidant supplementation. Now, in which indication, like in which patients should we use subfertility? What is the diagnosis? Which patients with which diagnosis benefit from treatment? So as you can see, in women with polycystic ovarian syndrome, they benefit from the antioxidant. It was borderline for women with tubal factor fertility. But for different indications, there was a recent study that there was a recent meta-analysis that looked at for whatever the cause, it actually, these women benefit. Women with unexplained infertility, they benefit from the treatment. And with women with poor reserve, definitely they benefit from treatment. So I guess the message is all women with regardless of the diagnosis will achieve a higher live birth rate if they use antioxidants during their treatment. Now, the most important thing in women undergoing IVF, will they benefit from treatment or not? And the answer is right there. The database showed, the Cochrane database showed that actually supplying these women with antioxidants does improve the outcome in terms of live birth. I like this Cochrane database because it focused on, I like this review from Cochrane because it focused on the most important thing to patients. They didn't focus on number of eggs or quality of eggs. That doesn't matter to the patient. They want to go home with a baby. And definitely this Cochrane database showed that the use of antioxidants does improve live birth rates for patients, whether they want to achieve pregnancy naturally or they're gonna undergo IVF with us in our centers. Now, should we use combination or monotherapy? So combined antioxidants versus traditional folic acid. There was a very nice prospective trial of multiple micronutrient supplement in subfertile women undergoing ovulation induction. And it was fairly recent. It's about 10 years now in age. And this study looked at subfertile women who are undergoing ovulation induction with standard treatments with clomiphene citrate or gonadotropins. And they looked at giving women folic acid, which is the standard practice, or if we add on top of it multiple micronutrients in terms of supplements. And the result of this study suggests that women who take a just adjuvant micronutrient supplement have a higher chance of pregnancy compared to women that use folic acid alone. So the bottom line, the message is using supplements, antioxidants does improve the outcome. Okay, so they included 58 subfertile women. 56 women completed the study. These women were randomized to receive the supplement or to use folic acid alone. And their outcome was clinical pregnancy rate and blood nutrient concentration after completing their third cycle if they didn't get pregnant or as soon as she achieved the pregnancy. So as we all know, most women will, they have a higher chance of achieving the cumulative pregnancy rate after 3 trials of treatment are high. So that's why they included 3 treatment cycles, or if they got pregnant from cycle number 1, 2, or 3. The micronutrients included were focused here in the study, including vitamin B complex, folic acid, vitamin D, zinc, selenium, vitamin B, etc. So it was multiple vitamins in the micronutrients that they used. They used arginine, acetylcysteine, and pantothenic acid. Women who received the micronutrient supplement had a significantly clinical and statistical significant higher cumulative clinical pregnancy rate compared to those that used folic acid alone. Most importantly, the ongoing pregnancy rate was much, much higher in women that received these supplements. It was cheaper for women to achieve a pregnancy when they used micronutrients because they required fewer attempts compared to women that used folic acid alone, and this was statistically significant. So you can see from this randomized trial that using multiple micronutrients does improve outcome in natural pregnancy and in IVF cycle.
Can you hear us, Dr. Ayman? I think meanwhile, Dr. Ayman Aref, maybe he's off online. It's my pleasure to announce رجعتي أيمن؟ وقفت السرايا. No, we can't hear. Can you hear Dr. Ayman? السلايد اللي معروضة supplementation with ovulation induction وموقفة. Okay. Just meanwhile, until Dr. Ayman will be back, it's my pleasure to announce some of the announcement that we are going to have the basic operative surgical skill, which is going to be in 11 August in Sulaiman Al Habib Al Suwaidi. Yes, now we will come, Dr. Ayman. Yes, welcome, Dr. Ayman. Can you hear us?
Yes, hello. Yes, I can.
Welcome back.
Sorry, I don't know what happened there. It froze on me. I'm very sorry.
No, it's okay. Welcome. We make use of the time. Until you go back to the presentation, I would like to announce for 11th of August, basic operative surgical skill, which is going to be in Sulaiman Al Habib. So proceed, Dr. Ayman.
Okay, I think we stopped here. Shall we consider combination? You guys can hear me, right?
Yes, now it's clear.
Okay. So shall we consider combination or monotherapy when we are giving these patients supplements? Should we use folic acid alone, or should we use a multiple nutrients? And there was a very nice prospective control trial that looked at multiple supplementation with multiple micronutrients in women undergoing ovulation induction. And in these women, definitely the multiple micronutrient supplementation resulted in a higher pregnancy rate. They looked at, in this study, the clinical pregnancy rate and the nutrient concentration in 58 subfertile women. And it had multiple nutrients in it, which I'll come to later on. And you can see from this study that the supplementation during ovulation induction result in a higher cumulative clinical pregnancy rate and a higher ongoing pregnancy rate from the graph. The clinical pregnancy rate was much higher with supplementation of multiple micronutrients or antioxidants, and the ongoing pregnancy rate was much, much higher. So the bottom line is, why don't you give these patients, whether they want to get pregnant naturally or IVF, supplementation to help improve the outcome? The most important thing, it's the combination of these micronutrients. It's not each element. So multiple micronutrients does improve outcome, but not a single one, okay? Okay, so you want us to give multiple micronutrients. Which one should we consider? And what's the concentration of these elements and according to the evidence? So in women with PCO, this was a nice article that was published recently that looked at oxidative stress and outcome of antioxidant supplementation in women with PCO. And these women are under stress already. And they wanted to look, when you give these patients antioxidants, what is the outcome in the management compared to women that did not receive antioxidants? This was a randomized study involving 200 patients with PCOS. And they were randomized into two women that received the antioxidants and women that did not, okay? And they were given, the women that were randomized with antioxidants were given it, and women that were not were given placebo, of course. These women were given clomiphene citrate, and they were followed up to 6 months. The outcome measure, again, it's very important. These women want to get pregnant. So they looked at clinical pregnancy and menstrual regularity in women who are undergoing, women with PCOS who have irregular cycles. So again, the multiple micronutrients they used, they had different components, as you can see here: vitamin B complex, vitamin C, vitamin E, folic acid, magnesium, zinc, copper. There was statistical significance in the level of oxidative stress markers and antioxidant enzymes between the two groups. And you can see they looked at different things and they found that the groups were different. However, this is what's important to us as clinicians. Just by using the antioxidant supplement, the clinical pregnancy was much, much higher when you use the micronutrients. And the live birth rate, which is the most important number, was much higher when these women with PCOS used antioxidants with multiple components. So women with PCO achieve a higher pregnancy rate and when they use multiple micronutrients. So let's look at the literature for these elements. These are the different elements that are involved or the ones that have been focused on that probably our diets are deficient in for women trying to achieve a pregnancy. So L-carnitine, acetylcarnitine, arginine, cysteine, vitamin C, vitamin E, selenium, zinc, and we are all aware of the zinc and what it did during the COVID era, vitamin B complex, folic acid, and vitamin D supplementation. I'm going to navigate through this quickly for you guys. So there was a study done or a review published on the role of L-carnitine in fertility. It has antioxidant effects, anti-apoptotic effects, and anti-inflammatory effects. So it seems to play a big role in human fertility. Now, it's highly acetylcarnitine is a more potent form of an antioxidant. So carnitine is a very important player in terms of fertility. There are people who are taking carnitine just for the general health. So if your general health is better, your fertility is better. Now, There was a study that looked at the effect of adding carnitine on the ovulation induction in women using Femara or letrozole for PCOS patients. And they wanted to see whether or not this improves the outcome. They looked at endometrial thickness changes, ovulation rate, and most importantly, conception rate. It was a randomized controlled trial that included 40 patients that were diagnosed with PCO according to the Rotterdam criteria that we're all aware of. And these patients were randomized into two groups: a group that received Femara alone, Femara with carnitine, and a group that received only Femara plus placebo. And they used 3 cycles to see if they achieved the pregnancy or not. They used carnitine 2 grams per day from the first day of the menstrual cycle, and they continued until they achieved the pregnancy. And they used this for 3 consecutive cycles. What were the results? As you can see from this graph, the ovulation rate was much higher compared to placebo. The chemical and clinical pregnancy was much higher when carnitine was used on top of Femara for ovulation induction. The endometrial thickness was consecutively higher in women that used carnitine compared to women that used Femara alone. Thicker endometrium might translate back to higher pregnancy rate. That's why these women had a higher pregnancy rate when they used carnitine on top of Femara. So ovulation rate was higher, and the chemical and clinical pregnancy rate was much higher when these women used supplements, as well as endometrial thickness. So the conclusion of that study, that using supplements in form of carnitine on top of letrozole improved ovulation rate, chemical and pregnancy rate, as it's very visible from the graph that we can see down below. What about during IVF? So there was a very nice study that was published that looked at the administration of carnitine in women undergoing IVF treatment. And they looked at its effect on embryo quality and implantation potential. So they included 200 patients. And these women, actually, they used them and looked at them. They did IVF before without the use of supplements, and they did not get pregnant. They were given 1 gram for 82 days on average, and then they underwent, so about 3 months, and they underwent IVF again. There was no difference in the total number of retrieved oocytes and their maturation and fertilization rate before and after administration. However, they had better quality embryos. So the quality of the embryos was much better when they used the supplements. And as we all know here in the audience, that if you have a better quality embryo, it might improve the outcome. So administration of L-carnitine, what they found, improved the rates of transferable embryos, morphologically good embryos and good quality embryos for transfer when these women used embryos. So the outcome was, does the use of supplement, the outcomes they were looking at, the use of supplement, does it improve the way that the embryos look? Probably yes, because it's improving our egg quality as well. So what they were saying in this study, that if you give carnitine to these patients, if you use, again, an antioxidant, you might improve egg quality, which might improve the outcome of IVF cycle. Another study looked at supplementation of L-carnitine, and it looked at uterine receptivity in women that actually had previous implantation failure during frozen embryo cycle. And this was a double-blinded, randomized, placebo-controlled clinical trial. As we all know, randomized controlled trials are the strongest evidence available. And they wanted to evaluate the impact of adding L-carnitine to women undergoing a frozen embryo cycle. And these women had a previous failed cycle, and they wanted to see if endometrial receptivity was improved by adding antioxidants. So it was a double-blind placebo-controlled trial, and it included 100 couples that had previous implantation failure. And they either received the usual preparation that we give them, plus L-carnitine, 3 grams, so they had a higher dose, or they received placebo. They looked at endometrial thickness, implantation rate, chemical pregnancy rate, clinical pregnancy rate, implantation rate, and live birth rate. As you can see, for the women that received L-carnitine, the endometrial thickness was higher. The chemical pregnancy rate was higher. The clinical pregnancy rate was higher. They had a higher implantation rate. At the bottom line, what makes the difference to us and to our patients is what is the live birth rate. So the use of the use of antioxidants does improve outcomes, especially in women that failed before. So why do we have to wait until they failed before? Let's use it from the beginning to improve outcomes for our patients. So the conclusion of this trial that there was a significant beneficial effect of adding 3 grams of carnitine to women in terms of endometrial receptivity and in terms of pregnancy rate and live birth rate. What about other micronutrients that we're not very familiar with, like arginine and for use for women with fertility? L-arginine is the precursor of nitrous oxide. We all know from physiology, nitrous oxide dilates blood vessels and improves uterine blood flow. With improved blood flow, we have better follicular growth, better oocyte quality, better fertilization. Arginine supplementation in poor responder patients does, in some studies, improve number of oocyte collected and transfer of embryos. It does improve ovarian response to our stimulation. It does improve endometrial receptivity as well as pregnancy rate. So this was published in studies. This was a study from Japan that looked at endometrial growth and uterine blood flow. They looked at L-arginine in terms of improving endometrial thickness in women with thin endometrium. Sure, Dr. Hamad, Prof. Mamdouh, the audience are aware that we have some patients that we stimulate them, whether for fresh or frozen cycle, we cannot improve endometrial thickness in them. So this might be a good player for these patients. So they wanted to look at, this was a university hospital in Japan, and they had 61 patients with thin endometrium, less than 8 millimeters. And they found that adding arginine does improve endometrial thickness in patients with thin endometrium. N-acetylcysteine is a sulfur-containing amino acid. It's a powerful antioxidant. It has been reported in the literature as a safe adjuvant for clomiphene citrate for women that are undergoing ovulation induction. And they found that it does improve ovulation induction and pregnancy rate. They showed that it might also improve insulin sensitivity in women with polycystic ovarian syndrome. So this was a study that was published from Italy that looked, and they showed that supplementation with N-acetylcysteine might improve gonadal function in women with polycystic ovarian syndrome. And it does have effect as metformin. When I was going through my residency, we used to swear by metformin. Metformin is falling out of favor in terms of these supplements, and they are taking over the practice in terms of improving outcome for these patients. It does, N-acetylcysteine does improve insulin sensitivity, and it's an alternative supplement to metformin. We still need further studies to be published to actually say that N-acetylcysteine is better than metformin in improving insulin resistance and improving outcome in ovulation induction, but the evidence is emerging very, very quickly. Vitamin C and vitamin E are antioxidants, and it has been shown recently in the literature to improve endometrial thickness as well in women undergoing IVF treatment. So supplementing these women with vitamin E and vitamin C, I'm aware of some colleagues that give vitamin E alone. We have some supplements in the market that contain vitamin E on top of the other micronutrients, as I have shown you before, that might improve the outcome in these women. So in terms of lab studies, they have been shown the adequate amount of vitamin E in follicular fluid increases the amount of maturation of oocytes. So vitamin E is important in reproduction. So please keep that in your mind when you are treating patients with fertility. Now, again, in women with PCO, supplementation with vitamin E in this study showed that it improves oxidative stress, and it is an antioxidant, does improve the outcome. It does improve pregnancy rate. So I can show you, so I showed you here that there are multiple players. Vitamin C, vitamin E does improve outcome in these patients. I'm just going to skip through this quickly because the evidence is there. Selenium and zinc are essential elements, trace elements that we should look for. We have seen that during the COVID era, supplementation with zinc might improve outcome. Zinc plays an important role in insulin metabolism. So in women with PCO, studies have shown that they have lower zinc levels. And studies have shown that women with zinc deficiency might be associated with abnormal lipid profiles. In animals, not in humans, zinc deficiency has been associated with impaired implantation, abnormal ovarian development, and oocyte maturation. So you can see the message I'm trying to get across here, that women with deficiency in all of these supplements, selenium and zinc, and the other micronutrients, I'm not going to go through these studies in details. We can discuss it later on in our question and answer session, that women with deficiencies in these micronutrients, they have a difficult time or a more difficult time achieving a pregnancy. So if you can shorten the time to pregnancy in these patients, please do it. It's safe, it's easy, it's nutrients you're giving them, you're not harming these patients. The vitamin B complex as well has been shown, vitamin B deficiency in these women has been shown to make the response less. So giving them vitamin B complex as well improves the outcome in these patients. I'm not going to go through the studies in details. Folic acid, we all know that it is recommended for these women to take folic acid as well. And folic acid is important to have a normal baby. So supplementing it from before a woman gets pregnant is very, very important. Now, vitamin D is taking a big role. Multiple studies, actually just a recent study published last month in Fertility and Sterility showed that vitamin D resistance or vitamin D deficiency is associated with poor outcome in IVF patients. And the recommendation was to supplement these women with vitamin D as well. It improves endometrial thickness, it regulates the menstrual cycle, and it improves implantation rate during IVF treatment. There was a recent randomized control trial and systematic review that was done to look at this. Vitamin D supplementation is beneficial for follicular development and menstrual regularity in women with PCO. So, is there an added value for supplementation with antioxidants? Yes, we should use combination treatment. I showed you the elements we should consider. The correct measure, the correct amount of each supplement is variable in the literature, but we are getting closer to the correct answer. And I think we should supply these women for at least 3 months when we are giving them. Eva Pharma has a product called Carnivita for both men and women. It has all these components. It has been approved by the Saudi FDA just recently in May 23. With Vision 2030, مع رؤية المملكة 2030, we want everything manufactured. We actually, the Eva Pharma actually just received the approved to be manufactured here locally in Saudi Arabia. It's manufactured in Egypt, but it's going to be manufactured in Saudi. So why not use a Saudi supplement for these women to help improve the outcome for these patients? It does have all the components I told you about in this lecture. It's used for PCO, unexplained infertility, and IVF exit preparation. We use it as 1 to 2 sachets for 1 to 3 months, and you can see the components they have is all the components I was talking about: the vitamin B complex, the folic acid, selenium and zinc, vitamin D, acetylcysteine, vitamin C as well, and L-carnitine in the form of 1,000 milligram. So I think if we use 2 grams of L-carnitine, that seems to be the target dose for improving outcome in these patients. I hope I benefited you and I wasn't a heavy guest on you, and I give the mic back to Dr. Samir Sindi.
Thank you very much for your excellent presentation. I love it, actually. Just before we go to questions and answer, and we have a few announcements. One, which is we are going to have a basic operative surgical skill, which is going to be the basic operative in 11th of August in Sulaiman Al Habib Suwaidi Hospital. Our colleagues are going to show it to us through a Top House conference. And we are going to have the 5th Saudi conference on gynecology and reproductive. It's going to be in Hilton in 24 and 25 November 2023. And it's my pleasure now to invite Dr. Hamad Al-Sifayan, Dr. Prof. Mamdouh Iskandar, and Dr. Ayman Arif to join us in our 5th Saudi OB-GYN conference. We are going to have hysteroscopy workshop also the day before. So it's our pleasure that all the participants to join us to our 5th Saudi OB/GYN conference. I think you also, Dr. Ayman Arif, important point about vision of Saudi Arabia, and this is from actually in 2030, that how we do investment for Saudi Arabia. And I would like to share with you now, since you raised that point, Dr. Rami Mahdi, he's a senior product from the pharmacist. He's going to give us some idea about this investment and about, since we are going to be another factory going to be in Saudi Arabia, and this will encourage more Saudi employee, more pharmacies factories going to be here. So if you allow me, we'll just ask Dr. Rami, please welcome Dr. Rami to join us to give us small talk for a few minutes to give us about the investment and about the factory which is going to be in Saudi Arabia.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Samir, for the nice introduction. And we are as Eva Pharma, we are honored to sponsor such a great webinar, scientific webinar, under the leadership of you, Dr. Samir Sindi, and for sure the wonderful speakers, starting with Professor Mamdouh Iskandar and also Professor Hamad Sufayan, Dr. Ayman Arif. Really, thank you very much for being with you today. And just as you mentioned, Dr. Samir, we are now in Saudi market. We are authorized as a Saudi manufacturer here in Saudi Arabia, and we are investing. Our investment here reached more than $100 million in building factories and also research center here in Saudi. So we are really proud to be here in Saudi. And as you see, Dr. Samir and all the audience, Eva Pharma now available in almost 41 countries. And we have currently 3 manufacturing sites. We have the Haram facility, which is internationally accredited by European, Canadian, and GCC regulatory bodies, enables exporting different dosage forms such as vials, ampoules, sachets, tubes. Almost all the pharmaceutical forms are manufactured in the Haram facility. We have also a state-of-the-art facility, which is 6th of October facility, which is built on 125,000 square meters to upscale our manufacturing capabilities, and also producing tablets, capsules, sachets, soft gelatin, plus dedicated area for cephalosporins and future expansion for human and animal vaccines. And the last facility, which is 10th of Ramadan facility, first dedicated immunosuppressant manufacturing facility in Egypt. So we are international company with a big factories for manufacturing. We are manufacturing a lot of dosage forms. Almost we are covering all dosage forms, starting from solid dosage forms, and we have also the vaccine planet, and we have also soft gelatin capsule. Almost we have all the forms are manufactured in our factories. Plus here also you can see, Doctor, that we have innovation research. We have also here the innovation. There's the Mark facility, which is considered the Innovation Research and Development Center. Mark facility is the largest dedicated site for pharmaceutical development and services in the MENA region, Middle East, North Africa. So we have also a very big facility for development and research, which is very important to offer new medications to support all patients in the world. Over 100 experienced scientists operate on the site of Mark Innovation for Research Center. If we go, also we are accredited, main accreditations for Haram facility. We are accredited from European Medical Agency and are following all the requirements to be accredited from European Medical Agency. Also for Saudi FDA, also we are authorized to from the Saudi FDA. So our products all meets the requirements for the all Saudi patients. Also from the Gulf Health Council, and a lot of also authorities we are accredited from. And also we strongly believe in the strategic partnership with big pharma companies like Lilly or Gilead, and also Boston Scientific company. We are also partners for all these international companies in using our manufacturing facility to offer our products for all the covered countries. This is just a small introduction about our investment in Saudi Arabia and our company as Eva Pharma. And really, I appreciate all the speakers for the nice presentations, and also special thanks for Dr. Ayman Arif, who makes my mission is very easy. Just we have now launched Carnivita Advance for women in Saudi Arabia, and it is available with the 13 elements to maximize the chance of the female in her infertility journey. We are covering almost the micronutrients which mentioned in the lectures of Dr. Ayman Arif. In Carnivita Advance for women, we have 1 milligram L-carnitine, 5 milligram acetyl L-carnitine, and we will show in the coming slides what is the rule exactly of L-carnitine. We have 500 milligram L-arginine and 50 milligram N-acetylcysteine, and we know from the lectures that L-arginine and the production of nitric oxide and its role in the endometrial receptivity will be very beneficial for infertile women, and the N-acetylcysteine, and it's also the significant role that it will even support the metformin in the patients who are suffering from insulin sensitivity. And also we have zinc and selenium and a lot of antioxidant vitamins, including vitamin E and vitamin C, and as mentioned by our Dr. Arif and doctors, that its role in the infertility females, and vitamin E as a lipophilic and vitamin C as a hydrophilic vitamins and antioxidant will act in different medias, so it will support our infertile women with vitamin D3 and folic acid and B complex. All this combination considered like a formula, the best formula which can support the females. And as per the Cochrane library, I would like to repeat, but just I confirmed that really these supplements will add value as per the Cochrane library. The results here show us that the results will be favoring adding antioxidant versus placebo or non-users, especially for the outcome of live birth, which is the most important outcome for any female seeking fertility. So this is just confirming that supplements will add value. If we go in depth in this Cochrane library, the subgroups which are much higher benefited from the multivitamins or the supplements, we have the PCOS patients. Also, we have the patients who are suffering from unexplained infertility and patients who already with poor ovarian reserve. So these three profiles, I think adding such supplements will give them the benefits, and as we mentioned, the main outcome from the Cochrane library was live births, which is the main aim for any female seeking for treatment from infertility. One of the most important components, which is L-carnitine, which is available in almost 1 milligram in 1 sachet, it will increase energy production, reduce generation of reactive oxygen species, and reduce oxidative stress. And as we even heard from Professor Mamdouh Iskandar in his lecture, that these type of patients who are suffering from infertility already under stress. So I think adding such components will reduce this oxidative stress for these patients. Also will increase oocyte and membrane integrity and reduce apoptosis. By the end, it will improve oocyte quality. In acetyl L-carnitine, also it can cross the blood-brain barrier, and it will also support these patients to improve PCOS symptoms, reduce amenorrhea, restore regular menstruation by its action on the hypothalamus pituitary ovarian axis, considered postulated effect of N-acetyl carnitine. So we can conclude that we have main 4 functions to improve ovulation, oocyte quality, improve endometrial receptivity and thickness, and optimize hormonal balance, increase insulin sensitivity. All that can be achieved by using Carnivita Advance for women. And as we mentioned in the study of the Cochrane library, the most benefited patients are the patients who are suffering from PCOS, and we would like to do like ovarian induction for these patients using letrozole or even by using clomiphene citrate. Adding such like Carnivita Advanced for women will improve the ovulation rate, chemical pregnancy rate, clinical pregnancy rate on the top of letrozole for induction, and even there is improvement in the endometrial thickness for such patients. For the patients who we will use clomiphene citrate, also again, that will add value after adding antioxidant with clomiphene citrate here in blue. There is also significant improvement in the clinical pregnancy rate and also in the live birth rate. So it will add value for this type of patients. For the females who are already suffering from unexplained infertility, even adding antioxidant for such patients in blue, if we're comparing between adding antioxidant or adding folic acid alone, we noticed here that adding antioxidant will add more value than adding folic acid alone, with a significant difference, as you see in the clinical pregnancy and also in the ongoing pregnancy. So there is clear benefit. For the most difficult type of patients, which are the patients here in the study, we have 214 patients with previously failed IVF or embryo transfer, were administered L-carnitine for almost 3 months, and they underwent again IVF and embryo transfer again. We noticed here, even for this type of patients, which considered difficult cases, that transfer embryo rate on day 3 after adding L-carnitine was much higher. It was reached 67% versus 60%. And also for a morphologically good embryo rate on day 3, still also there is significant here improvement, 45% versus 46%. And the most achieved improvement were here in the morphologically good blastocyst rate on day 5. You will notice here almost there is doubling in the improvement in the morphologically good blastocyst rate on day 5, which also will improve, inshallah, the pregnancy rate for such a type of patients. Again, we are available now in 2 forms. One form for female, which contain all the mentioned elements earlier, and also we are lucky to have also another form specified for males with different ingredients to support the male, specifically in the unexplained infertility. If there is an issue with the semen analysis, also here, that this form with its components designed mainly for male, and this one designed mainly for female, will add value, inshallah, for all infertility patients, and will support them to get pregnant, inshallah, in a lot of cases, as we mentioned. So we will improve ovulation rate and the endometrial thickness in PCOS patients, improve gamete quality, endometrial receptivity, increasing live birth rate in ICSI and frozen embryo transfer cycles, improve female fertility, and increase her chance to conceive naturally. Very nice taste. So the users will enjoy the taste even of Carnivita. With a flexible dosage, it can be used 1 to 2 sachets per day as your protocol. Duration also from 1 to 3 months. Really thank you again. And thank you, Dr. Samir, for allowing us to share with you such presentation. And now I can stop share to check the question.
Thank you, Dr. Rami, for your talk. Just I'll go for some questions and answer, and I'd like again to thank all our participants and our speakers, and I encourage everybody to register in Saudi Women Society, because they will have a special discount when they attend a conference or workshop. So welcome everybody. You can register through our Saudi Health CME, Saudi Health. So welcome to register there through the website. I'll go for a few questions for Prof. Mamdouh. One is asking from, her name is Mudumin Tibho. She's asking, cannot we do endo scratch for patients who are to do short protocol and are in the batch of IVF in center that they do a batch of a woman together?
Well, thank you very much, everybody. I really, first of all, I enjoyed all the presentations for the different speakers. And also, I would like to thank Dr. Samir and the pharmaceutical company for the invitation and for letting me be one of the speakers in this meeting. And to answer this question, I mean, if the colleague who asked this question, whether he believes in endometrial scratching or not, but if he does, then endometrial scratching, it depends. It doesn't matter whether you are using short protocol or you're using a long protocol. It doesn't matter whether you are doing it in a batch or you're doing it all the week through. Because the whole idea, it depends on when do you want to do the endometrial scratching. In some of the studies, it showed that you can do endometrial scratching the period prior to the period that you're going to start stimulation for your patients. And in some studies, they said that you can do the endometrial scratching on the day of the ovum pickup. So to simply answer this question, it doesn't matter whether you're doing it on a daily basis or whether you are doing it on in a patch for patients, grouping them together. I hope this answered my colleague's question.
Thank you, Prof. To Dr. Ayman Arif, another question, what is the role of myo-inositol alpha-lactoalbumin as a supplement in polycystic ovary patient undergoing IVF?
Again, thank you, Dr. Samir, for having me. It was a pleasure for me to be among you guys. I really enjoyed all the talks. To answer the question, I think it was given during the talk. We know that micronutrients are important. These women are deficient in certain elements. Myo-inositol in specific has been studied thoroughly. There are studies emerging, I should say, especially from the UK, that it might be helpful. We don't have clear data yet. Some studies say it does improve. Some studies say it's not. The data is still conflicting. I'm with the school of, as long as there is no harm, there is no harm in trying. But we should keep our eyes on studies emerging through it. One of the interesting things on the other side is cinnamon. Cinnamon is one of the supplements that we are studying at university now, that it is very helpful for inducing ovulation. We achieved about a 30% better ovulation rate in women using this supplement. So to answer the question in a short brief, it might be helpful. We don't know the evidence yet on it.
Another question to Dr. Ayman, does the carnitine improve egg quality for polycystic ovary patient without IVM?
I think the evidence is there. It's clear. We have shown if we can get better blastocysts, better day 5. So yes, it does improve egg quality. And the Cochrane database, I think, and all the other studies I've shown have shown that it is beneficial.
Do you have any comments before we close? Because of the time, actually, I would like Dr. Ayman Arif, Dr. Prof. Mamdouh, if you have any comments, you want to add anything from the point of women fertility and IVF. And it's again, would like to invite you because huge number are actually seeing you. So I would like to see you also in November, inshallah, in the conference. So if you have any comments, please say you have each of our colleagues for 2 minutes. You could talk anything if you like. So we'll start with Prof. Mamdouh.
Well, maybe I have just a quick comment and just to emphasize what I have presented in my presentation. IVF, especially when you are establishing a new IVF center in your area, I think very important points to take into consideration that you should start with the state-of-art equipments in your lab. You should start with a senior embryologist who is familiar to the equipments that you are going to get into your lab. So I think it's not the job of the IVF physician to choose the equipments, but it is the job of the embryologist, because sometimes you might get state-of-art embryologist equipments that your embryologist is not going to be familiar with, and he cannot use such equipments in the lab. Number 2 is you got to have your patient selections, and you have to select your patients very carefully. And number 3 is you have to have at least 2 IVF physicians in the unit, because sometimes when you face a problem, you can have the assistance of the other IVF physician. Thank you.
Dr. Ayman Aref, if you have any comments, please.
Yes. So again, patients, our goal as clinicians is to improve the lives of our patients by achieving their dream of parenthood. Having a good lab and a good IVF center is one of the key success to achieve that dream. But also we should use up-to-date knowledge of what's available in the evidence and in the literature to help these patients achieve this dream. The protocol used, the supplements that you use, everything that's any tool in your hand to help these patients achieve this dream, you should use it. Using antioxidants, using the correct FSH, all of that. On top of it, we have to be humans at the end of the day. These patients are desperate. Don't take advantage of that. Give them what knowledge says, and hopefully we will be able to help these patients achieve their dreams.
Thank you very much, Dr. Ayman Aref. Thank you, Prof. Mamdouh. Thank you, Dr. Hamad Al-Sifayan. Actually, Dr. Hamad, he went because he has some patients. So I'd like to thank all our speakers. I would like to thank IFA Pharmaceutical Company for their sponsoring. And I'd like to thank all our participants who joined us, more than 2,000 in the YouTube and 1,000 in the Zoom. So I'd like to thank them. It's a Friday, so I'd like to thank all of them for being with us, and I would like to thank Dr. Rami and IFA company for their actually supporting us. And here are some of our international speakers who will go to join us. We suspect another 3 international speakers will join us. We'll see you in hysteroscopy workshop or in basic operative surgical skill or in the 5th Saudi conference on gynecology obstetric in Hilton Hotel. And I encourage everybody to register in Saudi Women's Society, so they will have more and more CME, and they will have more lecture and conference. Thank you very much for your more timing, and I would like to see you again and again for such activity. Thank you very much, everybody.
Thank you.
يعطيكم العافية. يعطيكم العافية وجمعة مباركة.
شكرا جدا. شكرا. سلام.